So what did the consensus statement say about dermoids? Initially consider doing a relatively short term, but do follow them up maybe in 6 to 12 months and then maybe yearly. Many dermoids are small and they do not grow and they stay there, or they grow very slowly, which is why the idea was that they don't all have to come out. Fortunately, malignancy in dermoids are very rare but not unheard of. Maybe 2 or 3% will have malignant components, and when they do, these are bad actors. They often are squamous tumors in these dermoids, and these can be highly lethal. So if you see a dermoid that is growing, probably should come out. There are some unusual but specific appearances to dermoids. I had to go to the literature to find these cases. Remember I showed you the endometrioma with the fluid debris level, and the debris is dependent. If you ever see a fluid debris level but the debris is superficial, think about echogenic fluid in a dermoid with the floating fat. And that's seen here, and that's also seen on the CT scan. So that is distinctly unusual to have an echogenic fluid collection in the near field and a relatively echo-poor component in the far field. Floating fat. The last unusual variation are called these hair balls, or fat balls, if you will. And here you can see, these are just case reports in the literature. This was more liquefied at body temperature, and then they solidified, and there's hair and these floating balls. And that is supposed to be very specific for a dermoid, but unfortunately they are rare, so the literature does not have a lot about them in there. But if you should see something like this, think about a dermoid. Now, dermoids, because of the floating hairball on the fat, can be difficult to identify. And here we have such an example. In the right side, we're pressed to see a mass here. But if I told you clinically the woman had a right adnexal mass and you do not see the right ovary, step back and think about this case as to whether or not this could be an echogenic hairball floating on fat. Very hard to see in this kind of a clip, but if you push on it, as we're doing here on the other clip, now I think it's much more convincing that we're dealing with a focal mass because it's not being impressed upon with transducer compression, and notice the subtle but definite gradual acoustic shadowing. So now we're dealing with a hairball in a dermoid. That is a very subtle finding, and I think that's why a lot of people miss seeing dermoids. So consider doing clips of a variety of types. And if you have a transducer where you're pushing and interacting with the patient, think of this as similar to doing a classic pelvic exam with your fingers, but having a picture or camera at the end of your finger. Very, very good way to pick up these dermoids. Finally, the last category, the epithelial tumors in the ovary. These arise from the surface epithelium. They come in a variety of types: serous mucinous, benign, malignant, and based on biologic behavior, some have low malignant potential. But far and away, about 90% of ovarian cancer is going to subsequently be proven to be this type of tumor, and that is unfortunate. They do have a variety of types: the serous, the mucinous. You can see Dr. Netter's picture, and these are the deadly cancers in many, many instances. This is sort of the index example of an ovarian cystadenoma, complex, has thickening, septations, and whatnot. But notice, this is a benign cystadenoma despite its 25 centimeter size. Here's another example showing the extreme variation in these neoplasms. This too is a benign cystadenoma, but it is 11 centimeters in diameter, and hence is not as worrisome for being a malignancy because it looks very benign, being simple, but should come out because of its large size. So I don't attempt to tell a pathologist beforehand what I'm dealing with, especially if I'm dealing with a lesion that looks like this. If I see metastatic disease, and I certainly look for it, then I can suggest malignancy. But these should all come out and let the pathologist tell us what we're dealing with. Now, I just want to draw your attention to some subtle findings so that hopefully you're not going to find yourself in trouble. Here is a postmenopausal woman, and it looks like she has a simple cyst in her ovary, but I always put color on the ovaries, and in this case I saw flow, which is in excess of what I should see in a postmenopausal ovary, which led me also to look harder, and then I see this subtle mural thickening. And this patient, therefore, has not a simple mass, but a mass that has a solid component and has too much blood flow. So she has a neoplasm in this ovary, and she should go to surgery. And this is, fortunately, a borderline cystadenocarcinoma. What about this next case? This is a small lesion. If it's a young woman, and this was actually a 23-year-old woman, you might be tempted to just say this is a hemorrhagic cyst and let it go. But never conclude that before you put color on. And here we can see there clearly is some blood flow within this. My colleague who did this at the Brigham, if he did do a duplex, he did not photograph it, but he did for sure note that this was a vascularized area within this small mass, and wanted the patient to come back for short-term follow-up, which she did, and there was no change. At this point, this has to come out. And fortunately for her, this was a small tumor, only a grade 1, but look at her age. She was 23 years old. So this is certainly an eye-opener, if you will, because by all rights it should be a hemorrhagic cyst, but you can never make that conclusion before you put color on.